So our goal is to create the illusion. Now, just like this artist has painted this roadway to look like it's something it's not, he's created the illusion of a waterfall. We need to create the same illusion with our provisionals and with our final restorations, so that it's not possible for us to be able to tell the difference between an implant and a tooth. And the way we're going to do that is we're going to talk about now the custom provisional techniques that I utilize. And there's basically two categories to be discussed. The first category is the traditional healing time, and the second category is the immediate placement. Now, with either of these situations, whether it be traditional healing time after the patient has had the implants placed, the appropriate time is gone for the osseointegration, and the patient presents with us with the healing abutments in place, or if it's the immediate placement, where the situation is that the surgery's been performed and the patient presents for immediate fabrication of the implant provisional. Either one of these two categories, either technique can be utilized at either time, whether it be the direct fabrication or the direct indirect fabrication. It becomes your choice. What I like to do is now break this down into segments and talk about each one of the different choices that we have and cover them one at a time. So let's first take the custom provisional technique. This is during the traditional healing time. So the patient has had the implant placed, integration has occurred, and we're going to now go ahead and make the custom abutment and custom provisional with a direct technique and create the provisional in that situation. So the first one is the custom provisional technique, traditional healing time, and the two cases that we're going to discuss is the one that the two that you've seen highlighted in the lecture so far. The custom provisional technique, traditional healing time, the first case. Looking at this case, we know that we have the impending loss of the lateral incisors. So where do we start? With all procedures, same thing. We're going to start with the diagnostic phase. The position of the implant must be predetermined with the information derived from the diagnostic phase. We do need the study models and the radiographic findings and the clinical findings in order for us to plan the case properly. From that, the diagnostic wax-up can be created, and the diagnostic wax-up will aid in the fabrication of the surgical guide that we can forward to the surgeon and the creation of the provisional matrix that we're going to use to create our provisional. So in this particular case, osseointegration has occurred, the patient presents back to our office. What we want to do is take a look at what the patient presents with. Now, looking at this situation, we have two completely different tissue heights and tissue positions for both of these healing caps. Years ago, if we just took an impression of this and then made the final restoration, we'd have no way to determine if that would work or how that may look as a final restoration, and would be completely unpredictable. Fortunately, in today's world, we have different components and a different way to go forward with a case like this. So what we're going to do is we're going to remove those healing caps and we're going to place our provisional abutments. Now, as you can see, as we place the provisional abutments, we've sculpted this tissue to try to give it a little bit more even contours with each other. But still, we can see that these provisional abutments really don't support the soft tissue, and neither would the impression. If we were to take an impression at this stage, there'd be no way for us to predict what the soft tissue contours would be. So what we're going to do is we look from the top, the same thing. You can see that there's space around the provisional abutment, and really is inadequate for just moving forward with a final impression and final restoration at this stage. What we'll do next is we will modify those provisional abutments and sort of create an underlying abutment or tooth form shape that we would expect in a final restoration. And still, we can see the discrepancy between the abutment at this stage and the soft tissue, both from the front and from above, realizing that it does not really support the soft tissue that we have, which is key. And this is where we need to take control and create a provisional that's going to support those soft tissues and create a foundation to build the final restorations from. Now, with that, what we'll do is we'll take our Luxatemp in this particular case, and we're going to express some around the necks of the provisional abutments that we've created. And this is going to help to pick up some of the gap and create some material that we can then add more material into the matrix, and once we seat it, sort of compresses that material subgingival and three-dimensionally around those abutments to help create to capture some of that subgingival contour around those provisional abutments. When we remove it, this is what we start with. But as you can see, we have captured not only the tooth form that was created from the diagnostic wax-up that we've mimicked in our matrix, but we have some excess, which is good, which is exactly what we want, because we're going to need more at this stage to fill in the gap that's created between the provisional and the provisional abutment as it is right now. Now the beauty is if we turn it over, we can see by expressing some of the material around the neck of the provisional abutment first and then compressing it with the matrix, it actually helps and drives the provisional material subgingivally and will capture most of the time much of the subgingival contour. Now naturally it's going to need to be modified, but if we look, we can actually see that we've captured a good portion of that subgingival contour around the provisional abutment. Next step, we're going to go ahead and get out our handpiece, and we're going to start to shape this provisional, keeping in mind what shape, what subgingival contour we'd expect for a lateral incisor. From there, we're going to go ahead and fill in that gap because, as you could see, it was deficient in areas. So we're going to flow some composite around, and when we're finished, we're going to have essentially the subgingival contour of what of a natural tooth root for a lateral incisor would be. And once we bring it to place, now we can see that that provisional does provide good support for the soft tissue, helps to guide the soft tissue in its final growth and healing position, as well as support the interproximal papilla. From above, the occlusal dimension, and then onto creating the final abutments and the final crowns. Now later in the presentation we'll talk about how it is that we communicate with the laboratory where the abutment is, where that free gingival margin is on the abutment to create the natural emergence and natural aesthetics. But this is the final case based on the provisional. And if we were to compare these pictures to the provisional of the lateral incisors, they're very similar, and we've captured and supported the soft tissue and created an attractive smile. A close-up view showing nice healing and good tissue support. Okay? Now part of what makes this work in this case is Dr. Tarnow's 5mm rule. We see that we have been able to preserve the osseous tissue and the interproximal bone height, which predictably lets us preserve the soft tissue and the interproximal papilla. Now we're going to talk about the custom provisional technique regarding the second case. Same thing, traditional healing time. The patient comes from the surgeon. Adequate tissue has been developed on this case. If you remember, this was a type 2 type defect where there was both there was interproximal bone was maintained, but the palatal and buccal plate were missing. And our surgeon has removed the tooth, and he's done a wonderful job of providing us the soft tissue and hard tissue platform and base that we need to create beautiful aesthetics for the future. So we get the patient back. This is how they present. We remove the healing screw, and this is what we are presented with. Now, looking at this situation, same thing. If we were to go ahead and just try to take a final impression at this stage, we would really not be capturing what we need in the soft tissue architecture, and which would lead to just an unpredictable result. We're going to go ahead and place our provisional abutment, and same thing, we're going to remove it, and we're going to start with this case by adding to the subgingival contour and starting to create the subgingival emergence profile of a central incisor. We're going to go ahead and take this back to the mouth, and when I start to bring these back to the mouth, I decide at this stage, as I'm beginning to insert it, and get a feel for whether or not the contour is too much, if it needs to be added to or taken away from, to get a more natural scallop and gingival architecture here. And as we push it to place, we see that really, from a soft tissue position, both comparing to the other central incisor, that we have achieved about the support that we want, both facial soft tissue and interproximal soft tissue, with the subgingival emergence of this provisional. So at this stage, we're going to go ahead and prepare the provisional and start to create the margin and start to create the provisional to look like what we'd expect the final abutment to be. Okay? And here's the provisional taken back out of the mouth to get an idea of, again, the subgingival contour was created. Now we have the margin created. We can go back to the mouth to check it. If we compare this to a natural tooth, trying to look at its shape and its contour, we see that we've done a pretty good job of making it mirror the natural tooth contours of the adjacent tooth. So based on this, I'd expect our predictability in aesthetics to be pretty good. Our abutment in place, we go ahead and provisionalize, and you can let it heal the additional time you need to prior to the final impression. Go ahead and take the final impression, create the final abutment. The final abutment should really be very similar to the abutment we created in the provisional, allowing for soft tissue guidance, soft tissue support, both facially and interproximally. We can see it from above, and then the final restoration in place. Exceptional results don't happen by accident. It is the attention to detail that creates natural contours. Now let's go ahead. Now we're going to talk about the custom provisional technique. This is going to be the immediate placement at the time of surgery. So our patient has lost the tooth, but we've decided that there has been enough initial stability with placement of the implant that we can go ahead and immediately load this implant and create a provisional at the time of surgery. Now again, at this stage we can choose to do a custom fabricated chair side, or we can do the direct fabrication or an indirect fabrication, depending upon whatever it is that your comfort level is. Again, for this first case, we're going to go ahead and describe the direct technique, where the patient is presented straight from the surgeon, and we are now going to create the provisional. The clinician is in control of the soft tissue contours. The contours are up to us. The outcome that we achieve is dependent on our attention to detail. As long as the surgeon's given us what we need, then the rest of this should be very predictable. So immediate provisionalization technique, this is the first case. This is our patient. She ends up having a traumatic accident and the loss of her lateral incisor. We get her to the surgeon, and she returns to our office with a healing cap in place. We remove the healing cap, and what I've done here is I've placed the provisional abutment. Now, in my opinion, as I look at this, I realize, well, there's not enough support in soft tissue at this stage. But initially, I want to try the abutment in and see what it is that gives me and where I need to modify it and what direction I may take. So we'll go ahead and take it out, and as before, we're going to go ahead and start to add to the subgingival contour and create some of that emergence, again, of what we'd expect for a lateral incisor, and get a shape and contour that we want. I'm going to bring it back to the mouth, and initially as I go to put it in, it looks more like it's going to support the contour of the tissue that we need now, and I'm going to go ahead and push it down. And sure enough, if I step back and take a look, I think, well, from a lateral incisor position, this is pretty close. May need some minor modifications during the final creation of the provisional, and we'll see what we need to modify. But it gives pretty good facial support. The free gingival margin is about where I'd want it to be for a lateral incisor, with a little offset compared to the central and the cuspid. And this is what we have. We're going to go ahead and place a little cotton pellet in the access hole, so that we can go ahead and directly create the provisional, and we won't get locked into the screw space. At this stage, I'm going to go straight to the mouth. I'm going to take my flow composite, and I'm going to begin to flow composite around the provisional abutment, and I'm going to flow it to sort of creating contour as I go. Rather than make one large amorphous blob, I can go ahead and sort of create the contours of a lateral incisor, and we continue to add to it, and it begins to continue to grow until at least we finally get to a point where we're at a situation and a shape that we can start to contour and create a lateral incisor from. So we're going to take out our handpiece. We're going to start to shape what we've created with the flow composite, continuing to contour both facially and interproximally, and our lateral incisor starts to take shape. We're going to go ahead and remove it at this stage, and now as we can see, where I've created my soft gingival emergence part of the provisional, that was created initially, and that gave me approximately the support I need. And now I've created the tooth, and I know I have the tooth contours approximately where they need to be. What I need to do now is just join them together. So we're going to get our flow composite. We're going to go ahead and fill in that gap, join them, continue to go three-dimensionally, and now start to create and finish the shape so that it mimics the lateral incisor. Going to go back to the mouth, going to put it to place, going to stand back and take a look. At this stage, I still have the ability to modify the provisional should it need it. If I need a little bit more broad taper to the facial to give to make the scallop change position. Here's where I could broaden the facial part of the emergence of the provisional and change or influence the scallop. I could add to the interproximal if I felt that I needed to support or push the papilla to help close the space. But overall, this is pretty good contour, pretty good shape. We can take it out and glaze it and put it back to place. And now again, this is the day of surgery, so we know that we have to give this time to heal and give the papilla the ability to fill in this interproximal space. We can go ahead and screw the temporary in, tighten, and this is adjust our occlusion so we make sure that we don't have any centric contacts or excursions, and we present with the final provisional in place. Now it's a matter of just healing and allowing the soft tissue to be guided, and the soft tissue contours to be guided, the tissues to grow and become healthy, and then replace this with the final restoration. Okay, so we've completed our illustration of the direct techniques, both with traditional healing time and with immediate placement. We're now going to switch gears, and we're now going to talk about what I call the direct-indirect laboratory fabricated technique, where we can do a little chairside and laboratory components at the same time. Now the beauty of the direct-indirect is that it can be used at any technique that you feel deemed necessary either. It can be done at the immediate placement time of surgery, or it can be done after traditional healing. But also, our goal here is to create the custom abutment and custom provisional that is going to support the soft tissue and lead us towards the final aesthetics in the final restoration. So let's go on and start to talk about this. So we have the direct-indirect laboratory fabricated technique, and we're going to do that with this particular case. So here's a situation where the implant's been placed. This is a traditional healing time. So the patient has had the implant placed. Time is osseointegration has occurred. The patient presents back to me 3-4 months later, and this is what we present with. Now the reason I'm going to choose the indirect-direct technique on this particular patient is, as I first look at this, we have a patient with a lot of thick tissue and a relatively small healing cap. So when I look at this one, I realize that chairside may be more modification than I'm willing to do at this first appointment. So I take the healing cap out, and I realize that there is a small opening, tissue opening, and notice how tight and thick this tissue is. So in my mind's eye, if I today now sit down and try to create a provisional under these circumstances, I may have to do considerable lasering of the tissue over and over and over, trying to get the contours and continually going back and forth with the provisional. So in a case like this, I'm going to choose to do a combination of both. I'm going to do a little lasering to sort of create the contours that I need initially to sort of guide or start me in the right direction, but rather than do it all at once and overdo it, I'm going to do it in sections or portions. So chairside, we're going to laser the tissue a little bit. I'm going to put an impression coping in place. I'm going to take the impression of that situation. I'm going to take my impression coping and my analog. I'm going to put them together, make sure that they fit back into my impression. Now what I'm going to do in this case is I'm going to create, because we're going to be doing a laboratory fabricated component with this case, we want to create a soft tissue model as well, because we're going to want to take the soft tissue as it presents chairside with where I've sculpted it initially, preserve that in the model but in a soft tissue version so that I can continue my sculpting on the laptop under a better situation and create the contours I need laboratory side. So we're going to go ahead at this stage and we're going to flow in some Gingatech material, which is the soft tissue pink material, around the implant impression coping and abutment, and we're going to go ahead and pour the model. We're going to pour this in quick stone so that we can do this today if we'd like to do it today, or if we want to reschedule the patient, they go back to wearing the provisional they had and we can reschedule them. Sometimes my goal is that I'd like to do some of the laser recontouring, get myself started, do this quickly because this does not take very long, use some fast set stone, take it out, separate it, and now this is what I present with my impression coping in the model with the soft tissue model around it. Going to separate the coping, impression coping, from the model so that all we have left is our soft tissue contour. Now, I have exactly what I was left off with in the soft tissue chair side. I can go ahead and from there and evaluate my situation, try to get a better handle on how much more contouring, tissue contouring I may need in order to support the papilla and create the soft tissue scallop on the facial where I'd like it to be. As I look at it, I'm going to go ahead and decide. I'm going to get out a high-speed handpiece and a large diamond. Works very well to sculpt the soft tissue, and I'm going to do exactly that. So instead of maybe unpredictably sculpting the soft tissue in the patient's mouth at this time, I'm going to go ahead and sculpt the soft tissue on the model to take me the rest of the way home. I'm going to continue in shape and contour and widen it and open it and see what I end up as my final shape. Now, at this stage, I may elect, after I've seen what I've created here, I may elect to go back to the patient's mouth and do some more lasering and opening the contours this much, or I may just elect, because I've contoured it some with the laser, and I'm halfway there, I may elect to not do any more sculpting chairside, create the provisional here, and then allow by the pressure and the placement of the provisional to continue the guide the tissue. So I go back to the mouth. I've decided enough lasering. I'm going to take now my provisional abutment. I'm going to put it in the mouth. I'm going to start to create and shape my provisional abutment chair side in the mouth. I'm going to start to create abutment form and get approximately what I'd want the margins to be and the shape to be. But again, as you can see, this provisional abutment doesn't sit and fit the situation, soft tissue situation, exactly the way it needs to be either. There's a little gap and lack of contour here. So we're going to go ahead and take that provisional out that I've now created some of the contour in the mouth. I'm going to go back to my stone model, and I'm going to place it in the model. And as we see, if we look closely, we now can see the soft tissue gap between the provisional and what it needs to be in the mouth. And from above, we can see that there's a space between the provisional abutment and the soft tissue. So again, I'm going to get out my flow composite, and I'm going to start to fill in that gap around the abutment and create the remaining portion of the subgingival contour of the provisional. I'm going to light cure it. I'm going to take it out. And what we'll do now that we have the abutment again, we're going to start to refine it and finalize our margin, finalize our subgingival contour so it has the emergence that I'd like, and make sure it's just where I want it to be. Bring it back to the mouth and try it in. Now, what you'd see here is the difference between where I lasered and where the model, the benchtop model soft tissue contour was. And we go to place this provisional abutment in, and you're going to see that we're going to get some blanching, but kind of splitting the difference. If I had lasered the tissue all the way, then I may not get the support I need, whereas if I went ahead and used the subgingival contours and the provisional abutment to help push and guide the tissue, it'll bring me the final contours I need. Okay, so we finalize the provisional. We put a little cotton in the hole in the chimney, put a little Vaseline so things don't stick, and we're now ready to go ahead and take our matrix, which was fabricated from our diagnostic wax-up in our planning phase. Just like before, we're going to create the provisional, and we're going to bring it to place. And now we've been able to capture, again, both the soft tissue subgingival contours, both with a direct, indirect technique where we've guided the tissue the way we want to. We haven't overdone it one way or the other, haven't created any problems or too much stress. And we're going to end up with a provisional. Going to go ahead and take our final impression and finalize the restoration, and we end up with a nice final crown that'll help preserve and guide the contours. At this point, we're now into the hands-on part of the presentation, where we're actually going to go to the laboratory and create a provisional, just like I did what I call the indirect direct technique. We don't have a patient here today, but I think that we can sort of pick up, if you can imagine the patient in the other room, and we've sculpted our tissue, and now we've quickly moved on to the laboratory phase. We can create the provisional. So we're going to take some time and create the provisional on a model so that we can go through the steps.